Today's this from the emergency room to nurse. These are just some of my suggestions, but they're suggestions by a lot of my colleagues when we try to discuss how we can try and save. We mentioned in our previous talks trying to make hospitals more specialized in caring for the emergencies and the urgencies and the chronic care. We mentioned also trying to contain the cost of doing special imaging studies, and I think the Congress actually did something that was tremendous, which is actually to say that these expensive tests should actually be available to, if I had an MRI done for my lower back 3 months ago, and I'm now having the same pain without any further neurologic deficit, meaning it's not radiating elsewhere, there is really no great impact or need for me to do another MRI. If, however, I'm having fecal incontinence, I'm unable to keep my stool or even urinate, then obviously there's an indication for having it done at that stage. But having it available to all healthcare personnel, I know it's got to be HIPAA compliant at some point in time, but it has to be such an expensive test that it should be made available, especially if a patient had a cardiac catheterization and now presenting with chest pain and in the emergency room. I think we should have those expensive tests online where you're able to access it. However, again, here is the confidentiality of information and how information is shared. And here is where the lawyers, the politicians, the healthcare professionals need to come together. Is it so important for us to safeguard that information of having a cardiac evaluation done on you? Or is it more important for you to have that result available when, in fact, you deal with death and dying? I think the law that actually controls this, I'm no expert in the law, I will never be. But I think when you're faced with death and dying, you're faced with a life that could be saved, you're faced with also a tremendous amount of money that could be saved, especially if something is repeated there soon thereafter and costs a tremendous amount of money. And there must be some ways and means that these things have to be evaluated and be decided upon, that in cases of illnesses, results of things that are basically not considered confidential enough that someone could be using it against you, that basically should be privileged information given in a privileged situation. So expensive tests should be made readily available. So a patient who has had a previous CAT scan of the chest and now presents with something like mild shortness of breath, that CAT scan should be made available either online or by the services available whilst the patient is in the emergency room. Also, a patient who has had an MRI done before for persistent pain in the hip now comes in back 3 months after with a persistent pain, with worsening of that pain, should not have an MRI done immediately unless you've tried medication. But you should be privileged enough to have the MRI results when that patient is seen in the emergency room and not have another physician who's in the emergency room order another MRI for that patient. That is going to cost the healthcare system $1,500. It's going to cost them totally, by the time that patient leaves into institution, probably close to $5,000 to $6,000 for having spent time in the hospital. So I'm saying that the expensive tests should be made available for all of us to be able to view them and not having them repeated just because the patient is complaining of the symptom, when we know that the patient is not at risk for dying, but probably will have to wait another 24 hours. It will take that amount of time to even get it approved by the insurance carrier. But here, if our aim is to save money, then we should be able to see ways and means we can do it. Also, for that patient who is bedridden and at home, we should be able, as we did in University of Miami Jackson Memorial Hospital, provide home care for that patient. We should be able to send our residents at the hospital or our physicians as well to see patients at home. It will prevent them from having to call the ambulance, especially when that patient, let's say for instance a patient who's asthmatic, who's on oxygen, who's having mild shortness of breath. If you have a physician who's able to see that person at home, the relatives can call the physician and say, my mother or father is having the shortness of breath. Do you think we should put them in a nebulizer? Do you think we should call the ambulance? Are you available to see that person now? Or is it within the next 3 to 4 hours? If you find that you can rely on that person's information, then you can go there in 2 to 3 or 4 hours and see the patient and prevent that patient getting to the emergency room, ending up costing the healthcare system thousands of dollars from the time they enter there. Or a patient who's having belly pain based on constipation. Am I able to evaluate you for an acute abdomen versus chronic constipation? Do I do a rectal examination, find you have impacted stool? And do I ask you to digitally disimpact it and save you that hospitalization? It's so important that we all be given some guidelines on how to treat patients who are bedridden or home-ridden based on a simple fact of what the disease processes are. For the person who's having an excessive amount of gas but complains of mild chest discomfort without any evidence of exacerbation of a cardiac condition, should that person be rushed to the emergency room with an ambulance, have an EKG, have blood gases done, have blood work done, have an echo done, have a stress test done, then being admitted in the hospital for 3 to 4 days, running up a bill to close to $20,000 to $30,000, and have nothing changed in their diagnosis and treatment? It ended up costing our healthcare system $20,000 to $30,000. It did not benefit the patient. It did not do any change. It did not contribute to any change in the management of that patient. How often have I not seen in my practice with similar patients with similar conditions? If in fact that patient has worsened, obviously we should be able to send them to the emergency room. But I think it's safe if for saving $20,000 to $30,000, if it costs a physician at the $100 to make a home care visit, it should be done. A more qualified individual is able to make that decision is why it's important for us to try and save money on home care. The patient with a decubitus ulcer, that the pressure sore that now starts to bleed, doesn't need to be rushed to the hospital. That can be treated, but it needs to be examined and then treated and evaluated thereafter. It is not a reason for us to get an MRI done for the bone to see if there's or a bone scan done to see if that acute ulcer or that pressure sore now has invaded the bone. What happens now, that patient ends up in the emergency room, the resident sees the patient, decides, oh, it's close to the bone, it's on a pressure point, let's get a bone scan done, let's get a complete workup done, let's get urinalysis done because she has a low-grade fever. We ended up costing our healthcare system thousands of dollars for something that could be very well easily managed at home by a trained physician or a trained registered nurse or a trained nurse practitioner or physician assistant. Those are some of the ways and means we can try and help to save some money in the healthcare industry. Thank you. That's all for now. With the present economic downturn, I've started to notice an increasing number of patients in my practice presenting with, doctor, I've started to use alcohol a little bit more frequently. I've started to smoke when I stopped smoking 2 years ago. I've now noticed that my child who is in college or who is in high school, I find their behavior a little bit different. They are much more relaxed, but they don't do their work anymore, and I think they're on marijuana. I've also found the complaint of my child seems to be on cocaine because at times the behaviors goes up and down. What I'm alluding to is that we found in our practice an increasing number of patients, when faced with the economic situations that we have today, are turning to drugs. Unless we understand that some of the understanding out there that some of these drugs have no side effects on us, then we're missing the bigger picture. For instance, a lot of us will be aware of the common drugs that we see, alcohol, tobacco, but there's also cocaine, ecstasy, heroin, ketamine, meth, prescribed drugs, prescribed medications mixed together, over-the-counter, and steroids. The ones we commonly see in our society that I can describe and basically assure you that abuse of it is probably to your detriment rather than solving the problem. Let's, for instance, address the issue to do with the increased incidence we're facing now with tobacco abuse. The chronic smoker tells you that when I do not smoke, I feel jittery, I feel I can't function, I can't focus. That may very well be true. It's not a bad explanation because nicotine is a stimulant, but it's also a very addictive stimulant. But the raw facts about it is tobacco use is the leading preventable cause of death, disability, and disease process in the United States. I'm quoting from statistics between 1964 and 2004 that says that cigarette smoking caused an estimated 12 million deaths, including 4.1 million deaths from cancer and 5.5 million deaths from cardiovascular disease. An alarming statistic if you can actually say that it's a leading preventable cause of disease, disability, and death. It leaves us with no option that we should find an alternative to cigarette smoking. And we cannot turn to cigarette smoking as a means of relieving our symptoms or assist us in being able to function. Because if we're going to become a statistic, we can become one of that 12 million deaths from it, or 4.1 million deaths from bronchogenic cancer. When you smoke, the smoker inhales the tar or the nicotine, which actually causes the dopamine in the brain to actually be stimulated, and you feel as if you are excited, or you feel good, or you have the drive you want to function. That is the role of the stimulant. But in addition to that, when we inhale it, we inhale about 200 hydrocarbons, including carbon monoxide, and that in itself, when we inhale it, that is what causes, if we inhale it, it goes down into the bronchus. That is what causes the damages to the lungs. Initially, it causes damage to the alveoli of the lungs and basically destroy them. So instead of us having nice, good lungs that are well aerated, we have this large, voluminous lungs that are not well aerated. We start to suffer from mild shortness of breath that becomes increasing shortness of breath. But in addition to that is that the bronchus, or the main airways, actually become the focus of common causes of cancer. Also, in addition to that, it accelerates the process of coronary artery disease and basically causes us to have premature death from heart disease when we actually become chronic smokers. So we get the relief that we need because we're able to function. But nicotine addiction in itself causes a diffuse disease process to your blood, to your arterial system. Not only does it affect the coronary arteries and increases the risk factor for heart attacks, it also decreases the blood flow to the carotid heart arteries, hence increasing the risk of stroke or narrowing of the carotid arteries, which decreases the amount of blood flow to the brain. So it is a stimulant at that time, but it's not the fact that something is wrong with the stimulant, but the fact of what the damages from chronic tobacco abuse does to us. And secondhand smoke, meaning breathing in from someone else, is equally as significant in causing the side effects of the damages to the lungs, the damages to the heart, also the increased risk of nasopharyngeal cancers, bronchogenic cancers, also prostate cancers, and urinary bladder cancers. So tobacco smoking as it is, which is a very, very common habit in our society, and which is one that I've noticed in my practice that the patients I'm seeing are starting to increase the abuse of, should be something that should be discontinued at all costs. Another fallacy that I hear is that a parent comes in, brings in the young adult son, most commonly, daughters are now included as well, that my child is smoking weed, or Indian hemp, or ganja, or Mary Jane, or whatever name you want to call it. Is there a risk for them? The teenagers believe that there's no risk. But studies have borne it out that when you take it, it makes you relax and you feel good. But a person who starts as a teenage smoker is more likely 50% of a chance to end up needing depressive medication as they get older. Or the increased risk of schizophrenia, which is a disorder of thought, emotion, memory, and perception that is a lifelong illness. So starting marijuana smoking because it's cool, because it makes you feel relaxed, because it makes you feel as if you want to manage your situation better, because you don't have to confront the world as you see it, but also because your friends are doing it, is a habit that should be discontinued. And it is a dangerous habit as well. The active ingredient of marijuana, THC, or tetrahydrocannabinol, is dangerous for us to use on long-term basis. I've heard patients say, but I only smoke a joint per day. The chronicity of it and the long-term usage of it definitely affects you in the long run. It helps you cope with your situation now, but so does exercise, so does going to your religious organization also, but it doesn't have the side effects as marijuana usage has. So